All right, let's jump right into a scenario that is an absolute classic for your ortho exams. We're talking about a mid-shaft humerus fracture. But this isn't just about a broken bone. Nope, this one comes with a serious complication, a radial nerve palsy. How you manage this is honestly what separates a pass from a fail. So let's get you ready.
So here's how we're going to break it down. First, we'll look at the clinical problem itself. Then we'll explore the two big schools of thought. Should you wait it out or should you operate early? After that, we'll peek into the surgical strategy and finally dig into what the latest evidence says about which approach actually gets better results.
Okay, let's set the scene. Imagine this. A patient walks into your clinic, or more likely, your ER. They've had a fall and their arm is clearly injured. So what's the first thing you do? You get an X-ray.
And here it is, bam! A pretty standard-looking fracture right through the shaft of the humerus. You can see the bone is broken, no doubt about it. But here's the thing. The most important part of your diagnosis, the thing that's really going to test you, isn't something you can see on this film at all.
It's what happens when you ask the patient to do something simple. Can you extend your wrist for me? And they can't. You see that classic wrist drop. That one clinical sign, well, it changes absolutely everything. It's shouting radial nerve injury, and suddenly, your whole management plan has to account for both the bone and the nerve.
And you know, this isn't some rare, once-in-a-career thing. Not at all. We're talking about an incidence of around 12%. That makes it the most common nerve injury you'll see with a long bone fracture. So trust me, you are absolutely going to encounter this.
And that brings us right to the heart of the matter, the big debate you'll need to discuss in your Viva. Do you go with watchful waiting, what we call expectant management, and just see if the nerve recovers by itself? Or do you take the patient for an early surgery to fix the bone and get your eyes directly on that nerve?
So first up, let's make the case for the traditional approach, which is watchful waiting. For a long time, this has been the standard of care, and for a really good reason.
And this number right here is that reason. Look at that. A spontaneous nerve recovery rate of over 95% in fractures that are just managed in a brace. I mean, wow. That is a massively powerful argument for staying out of the operating room, right?
Now, why is that recovery rate so high? It's because most of the time, the nerve isn't actually severed. It's what we call a neuropraxia. Think of it like the nerve has been stunned or bruised. The wiring is all still intact, but the signal is just temporarily blocked. And just like a bruise, it almost always gets better on its own with a bit of time. But let's be clear, waiting does not mean doing nothing. It isn't active surveillance. You're closely monitoring the patient, looking for those first little flickers of recovery. The first place you'll usually see it is in the brachioradialis muscle, maybe around the 2-month mark. Now, if you get to 4, maybe 6 months and there's still absolutely nothing, well, that's your trigger to start thinking about a delayed surgery.
Okay, so even though waiting works most of the time, there are some definite situations where waiting is just not an option. In fact, it would be the wrong answer. These are the times you have to go to surgery, and early.
And these are them. These are your red flags, the absolute must-know indications for early exploration. If it's an open fracture, if there's damage to the blood vessels, or, and this is a big one, if the nerve palsy only showed up after you tried to reduce the fracture in the ER, you're going in. These signs all suggest the nerve is in big trouble, maybe trapped or even torn.
The whole argument for operating early really boils down to one word: control. This quote sums it up perfectly. Going in lets you see exactly what's going on with the nerve. Is it just bruised? Is it trapped in the fracture? Is it severed? You can figure it out right then and there and fix it, which can prevent a whole host of problems down the line.
All right, so you've made the call. The patient is going to the OR. So, what does that actually involve? What's the plan?
It's a pretty logical 3-step dance. Step 1, you explore. You carefully find the radial nerve and see what state it's in. Step 2, you intervene. If the nerve needs help, you give it. Maybe that's just freeing it up, or maybe it's a direct repair. And finally, step 3, you fixate. You stabilize that fracture, usually with a plate and screws, to give both the bone and the nerve a nice, stable home to heal in.
And you can see that first critical step right here. The surgeon has found the nerve, that white cord-like structure, and is very gently checking it out. You're looking to see if it's intact, if it's caught on a spike of bone, or if it's stretched taut across the fracture. And this is what it looks like at the end of the day. The fracture is perfectly put back together and held strong with that plate and screws. This kind of rigid fixation is exactly what you want.
It lets the bone heal reliably and keeps the recovering nerve safe from any more irritation. Okay, so this is the moment of truth. We've got a solid historical reason to wait and some very clear reasons to operate early. But when you put them head to head, what does the best, most current evidence actually tell us about the outcomes?
Well, this chart pretty much says it all. This is from a big systematic review. And just look at those numbers. Early surgery, we're talking within 3 weeks, had a nerve recovery rate of almost 90%. Compare that to the non-operative group at 77%, and look what happens if you wait and then operate late. It drops way down to 68%.
So the message from the data is really crystal clear. While yes, a lot of patients will get better without an operation, the group with the absolute best chance of getting their nerve function back is the one that has early surgery. And, this is a pretty big shift away from what we were all traditionally taught. So let's boil this all down for your Viva answer. Here are the key takeaways. Number 1, a humerus fracture plus a wrist drop means you have to suspect a radial nerve palsy. 2, the classic teaching is watchful waiting, and that's because spontaneous recovery rates are very high. 3, you must know those red flags that mandate early surgery. And finally, number 4, the latest evidence actually points to early exploration having the highest nerve recovery rate of all. And that leaves us with the big, thought-provoking question. If the evidence is so compelling, why isn't early surgery just the standard of care for everybody with this injury? Well, the conversation is definitely changing, but things like surgical risk and resources mean it's still a hot debate. And for your exam, being able to argue both sides of this evolving story, well, that is the key to a truly top-tier answer.